have between 1 to 5. So you let me even take 1. If you divide 6 million by 1,000, you're looking at 6,000. So we should have 6,000 emergency beds in Accra. What we have is not even up to a third. I'm not talking about bed space, I'm talking about emergency bed capacity. So we need to add more functional beds. So we are lacking physical space, not the furniture, but a space where you have beds with all the things you need to manage emergency. And that's why I was fighting a lot of, even my own folks when we were in office, to make sure that the police hospital, the police hospital we have there is like a 2-3 bedroom house. If you're outside, you see it as a hospital. If you go in there, it's a small place. You have this structure which is being built, it's been installed for years. And when I was a member of parliament, I went to ask the health minister, why are you not pushing this project? You need to have more beds. And he said, oh, it's for interior ministry, not under health. I went to Ambrose. I said, why are you not finishing this hospital? And it's important because some hospitals, because of their nature, that is where funny cases are taken to. When I say funny case, when you meet someone by the roadside who is unconscious, there are some hospitals that will not accept the person because you don't have relatives, you don't know what is wrong, but police hospital, by their nature, will take it. So they need more of these beds so that they can handle such cases. Number 2, Accra is having new beds coming on board, emergency beds, but they are for the privileged. So you have very good hospitals like Accra Medical Center, Bank Hospital, other hospitals. The ordinary man who is at Latabi Okoshi, when he collapses, their relatives will not drive to that hospital. In fact, ambulance service will not drive there because you must make a deposit. Their charges are, sometimes they don't take NHIS. If you have, let's say, there is appendicitis, and Rich would charge 2,000 if you don't have insurance. That hospital can take maybe 10,000. So some beds are coming, but they are not for the ordinary person. And so we must have a system that allows all beds to take emergencies. And there are 2 ways you can do that. This country can afford some levy. I'm not talking about even a new levy. Take a motor insurance. All vehicles in Ghana pay insurance. But some never go for any insurance in a year. We can dedicate some 5% of that amount to handle all emergency bills. So any emergency that goes to the hospital, nobody worries about the payment. First 48 hours, the bill will be sent, it will be paid by that insurance. Now, if you go to a private hospital with NHIS, they will take you. Insurance will pay NHIS, and then the gap. So assuming appendicitis would have been 2,000 at NHIS facility.
Hello? The demons don't like what you are saying.
Yeah. I mean, because I've also been part of the system, I have a fair idea of the issues direct. Bank hospital should take you for appendicitis, knowing that they charge 10,000, but we have a fund that will pay the difference of 8,000. Let's be blunt. Most of these hospitals don't take NHIs. It took a lot of effort from me to get International Maritime to start accepting insurance. I work in Tama General Hospital. All the cases from Asham and Pram are coming to Tama General. One time I went to International Maritime, they have all the equipment, fantastic place. In fact, I told them if I'm sick, I want to come here. But the place was empty. Why? Because they don't take insurance. Yet emergencies are going to Tama General, there's pressure on the equipments are broken down, but they have CT scan, X-ray, modding at IMA, and nobody is there. So these disjointed arrangements for the same population puts pressure on 2-3 facilities whilst the others are fine. In fact, number 2, I think that we need to, bad debt is what makes some hospitals avoid emergencies taking them. They will come, they need you to help them. You take care of them, nobody's showing up to pay. If the hospital cannot recover from that, the next patient cannot be taken care of. So we need to have a system where Ghanaians must have insurance. You know, when I did some masters in Germany. When I went to the class the first time, the lecturer was asking me for my health insurance. He was not interested in my school fees. So I thought for once I can finish and not pay the fees. And then then one day I asked them, why are they so much interested in health insurance and not the school fees? He said, if you finish school, the certificate will be with them. But if you collapse in class, they must pay for your bills. So the point I want to make is that they connect. Health insurance is basic. The university is responsible for your health. So they tell you, go and get health insurance. In Ghana, everybody driving has insurance for their car because the police can stop you. Where's your insurance? But the driver himself has no health insurance. So just as police can arrest you for your car not having insurance, this country must connect some necessary events to health insurance. Every child, before they move to the next grade, public or private school, they must have a functioning health insurance, whether private or public. Every adult, working adult, before they validate you on a payroll, you must have health insurance. Now, if most of the population have health insurance, then a law that says that take care of emergencies is easy to implement because the one coming is likely to have health insurance. Now in Ghana, when 100 people rush to any emergency in Ghana, only 5 or 10 have health insurance. It means the risk of high deaths, hospital deaths, is very high. And this is something we have to connect. And then finally, let me say that it is very sad. In this country, you can be the most hardworking doctor, but you never get to be a manager of a hospital. We don't have objective ways of appointing heads to manage hospitals based on their track record and performance in the same hospital or other hospitals. So you have someone who's been in the system for long, just because of that, he's made head of a facility. And in his hospital, cases are being referred when they could have been managed. But nobody audits the referral. In another hospital, you have a very good manager who is making sure no matter the pressure coming, he, like doctor is saying, if the hospital, the emergency is full, he's giving directives. Make sure you move to the urology ward if it's free. The next doctor says that, my emergency is full. No independent assessment looks at who is performing. And the worst case is that if the doctor who is managing his place very well, a public hospital, helping us manage emergencies, is not having friends who are the regional directorate, or is not in the good books of those who are managers in a region, or forgive me, is not known to be connected to a political party, or is perceived to be friends of the opposition, the best doctor rather is transferred because somebody has reported him that he is not sympathetic to the government that has come. So this is what I'm trying to say. First of all, just as we have maternal audits, maternal mortality audits, we must start having referral audits. Because some hospitals refer cases that they know that should anybody come and audit them, they wouldn't have referred. Other day, I've been in hospitals where cases move from, let's say, one hospital to police hospital. It moved only for convenience. Because we want to sleep this evening. This case is a bad case. If we take this case, everybody must stay awake. But if those in the hospital know that the case that has been referred has been captured, and in 2 months' time, there is an audit of referrals, you will not refer. So there must be referral audits. And then the quality of your referrals should be part of assessing the head of the hospital to see whether you stay on or you are moved to another hospital. Ghana must, and our sanction regime should be strong. Other day, I know people, most of the people who died through this no-bed syndrome, when we even do the technical investigation and we find out that somebody's at fault, we don't have the courage to sanction people. The chiefs start begging, MPs start calling you, and that's why most of all these instances of no bed, all the reports are there, but all the people are at post. Not one has moved.
Oh, let's put hands together for Dr. Okoe-Boye. Wonderful. So the good news is that we are capturing all the proposals. Even my very small mind, I've captured over 10 different proposals from the speakers, and I'll try and summarize at the end.